Hello and welcome to the Mining View. I'm Jackie Allison. It's my pleasure to be here with you in my first LinkedIn Live interview. I'll be doing a series of these to bring to you topics of interest in mining, mining-related topics of all sorts. And so we're going to start today with a very topical issue. This is affecting everyone, not just mining. And so it's my pleasure today to introduce Dr. Philip McMillan. I'm sorry, we're just having one technical difficulty. He'll be with us shortly. But this is the first of the series. We thought we would start with COVID. Of course, it is important for everyone to be understanding what this is all about. We've spoken of it briefly before in other ways, but I thought it would be a great way to start. To start off this series, to have him here with us. Dr. McMillan is in the UK. He focuses on a number of different research projects. He has focused in the past on dementia, and other complex diseases, and I think COVID-19 fits into that category as quite a complex disease. It has been with us now for 2 years, and there's still lots of understanding to come. So what he will do with us today is share his what he's been finding through his research and what implications this has for mining. So just let me try and understand what's happening here. He was with us a second ago, and we're hoping to get him back with us in just a moment. Hang with me 1 second, he'll be right back with us. So as I was saying, Dr. McMillan's focus, he's located in the UK. His focus on disease and understanding diseases and his research is on pathophysiology, which is really the mechanism by which diseases work. And so he's applied that in the past to dementia, and he's now applying this in the past 2 years to COVID-19. He published 2 papers on this, and specifically autoimmunity in COVID-19. And so what he will share with us today are some of those findings so that we have a better understanding of how COVID works. You've probably seen lots of research on this in the past. Various sources. Of course, we're trying to look for credible sources, those who can really understand the mechanism by which the disease works and the implications, therefore, that it has. And so I have with me today, Dr. McMillan. Glad you could make it on.
Oh, thank you. I must admit, I just had a little bit of a computer nightmare and disappeared temporarily, and I'm back again. Thank you very much.
So that people understand where you're coming from. Just to give you a bit more information about Dr. McMillan, he's, as I mentioned, the physician in the UK. He's the founder of Vision Health, and he's also founder of McMillan Research, which is really focused in right now on COVID. He's also president of Doctors for the World, which is DFW, a fairly new organization which is looking at a broad range of diseases, starting with COVID. So, Philip, I'd let you go ahead and say a bit more about yourself, and then we can jump into COVID and then try and link it to mining and see what the implications are there.
Thank you very much, Jackie. Really appreciate it. And yes, I think it's Doctors Federation for the World. Yes, it's something that we'll be focused on over the next few months as we build towards our summit and raising the profile of what we're doing to try and see if we can focus on changing some of the paradigms that exist with regards to health and healthcare. I think this is one of the things that I've seen most clearly in the pandemic is that I think medicine has drifted away from its roots in terms of understanding pathology and physiology of disease generally. And I think this is probably why we've been caught out by COVID-19. We've become so used to just treating symptoms and treating around the disease that COVID-19 has seemed to have hit us off guard. And so, yes, I'm really pleasure and honor for me to speak with you on this first inaugural presentation, Jackie, and to share with you some of the thoughts and the research that I've been doing with COVID-19. Most of my time has been as an interviewer rather than an interviewee, so I'll try not to hog the microphone.
Well, there's always lots of Q&A on the sessions that you have, and I think some of the people that are joining us today would have had a chance to to watch those interviews with a number of different experts in fields related to this. And so it's great to get the different perspectives to understand different parts of this better. And so today, I know you're going to focus on autoimmunity and COVID-19, and then we can see what implications that has for all sorts of things. But it explains so much. So I think it's important for people to understand, first of all, what is autoimmunity and COVID-19 before we dig into other things.
Yes, I think that it's an important starting point. And I guess, uh, uh, as I explained to people, I got into COVID-19 research just at the point where I had put enough pieces together with regards to dementia research, which I've been doing for like about 10 years. And I thought that I'd gotten just about enough to be able to change the paradigm as well for dementia. And I approached the disease by trying to find fundamental, basic, primary pathophysiology of a disease. And it was that kind of thinking that I used in the context of COVID-19. And so really, I just thought to myself, well, if I can be focused on brain health and brain operation, I should be able to use that technique with regards to COVID-19. So this is why I started the research in about February 2020, looking at all the data that initially came out of China to be able to try and make sense of what seemed to be a very, very strange pattern of symptoms that just never not been seen before. It wasn't behaving like a typical viral infection. I remember in those early days looking at things even like I remember when I heard about a lot of patients getting quite suddenly short of breath, in the evenings in Italy. And I was trying to work out, is this something like high altitude pulmonary edema? Because in order for somebody to get short of breath very quickly, there had to be some change in the lungs that occurred either with fluid or with regards to inflammation, because it just doesn't usually happen that quickly. So it was that phase of trying to figure out why the disease had so many unusual patterns that I stumbled into the concept of autoimmunity. And I think sometimes it seems straightforward to me as I'm thinking about it, but it really came out of months of looking not just at the research around COVID-19, but actually doing quite a detailed study on basic pathology and pathophysiology, how the body works. I was listening to lectures every day, listening and trying to work things out. And it was out of that work that the concept with regards to autoimmunity came about. And what I'm going to do is I think probably two slides without going into too much detail, trying to think about how to share this without it becoming too complicated.
Mm-hmm.
But the two concepts that stood out to me at the time, and one of them was that children weren't sick, and 76% of the patients in China had hypertension.
So I
That
guess the early findings, and so we know children can get sick, but it's more the exception than the norm for a child to get sick. So maybe we can get into that. Why does that happen later? But go ahead.
Yeah, so at the time, it was just that with the data that had been provided from China and in the Wuhan region, none of the patients were young. And
Mm-hmm.
that was a standout because I was thinking, we've got a viral pandemic, and yet, 76% of the people who were on oxygen had hypertension, and there were no children. That was really, really strange. That's not what I'd expect, because
Right.
certainly, especially little babies, should be very high risk for getting severe disease with a viral infection because they have such poor immunity.
Right.
So it was that question that really caused me to try and understand what could tie the two things together. How could you have no children, high amounts of hypertension? Because hypertension doesn't also put anybody at risk of any viral infection. So in the context of COVID-19, this was also an outlier. And that's how I approach research. I always went for the outliers. And it was in that piece of trying to figure out those two outliers as to why children, what would there be that wasn't in children, that was in adults with hypertension. And in that search, I stumbled into the concept of serum ACE2. And I truthfully had not heard about it at that time. Medics will have heard of serum ACE in the context of sarcoidosis, that's a special disease of the lung. But in terms of serum ACE2, I didn't know that it existed. And so this was really, really stand out for me. And just for those who want to understand the basics of what stood out to me is that the serum ACE2 here is just that normally the ACE2, this is what the virus
So,
uses to get
okay,
into the
that's
cell.
great. Yeah,
But
that's
yeah,
the point. What is ACE2? It's the entry receptor that this virus uses to get into the cells to replicate,
yeah, but it's not just an
typically.
entry receptor. It's just that the virus happens to use it. It's just
Right.
there.
Yeah.
It has a function with balancing a protein in the bloodstream, angiotensin 2, and it's part of the renin-angiotensin system. And so in most people, in healthy people, it's there. It's usually attached to the endothelial cell. So this is primarily in the bloodstream. So all of this is a blood vessel. The pink area is the bloodstream, and the ACE2 is attached to the endothelial cells that line the blood vessels. And in patients with certain conditions, older people and those with high blood pressure at the time, this enzyme that is called ADAM17 can clip this attached ACE2, and it then floats in serum. It's what we call serum ACE2. And actually, it's a marker that we can use even in heart failure. It tends to parallel another marker we use called the brain natriuretic peptide, or BNP. And so serum ACE2 rises in those conditions. And so I noticed straight away that the conditions that had severe COVID-19 were also associated with this. And so that's essentially what had triggered my thinking with regards to it, as to why I thought this was very, very important.
Hmm.
And it was beyond that, then trying to understand why would this elevation be associated with a cytokine storm, or a very, very significant immune dysregulation in severe COVID-19.
Okay, so we're going to get on to the symptoms, but just to go back to that one point you made, the high levels of ACE2 in the serum, what you call serum ACE2, is linked to certain comorbidities that we now know are factors for severe COVID. And so high blood pressure, people with high blood pressure, sometimes heart disease, diabetes, the obese, they tend to have higher levels of this serum ACE2. So right away,
That's
we
right.
understand that this plays an important part in whether you get severe COVID or not. So it would help in targeting, I guess, is if we needed to know who is really vulnerable or why, it's tied into this serum ACE2.
Yeah, and actually, it's I recently shared a post on LinkedIn about I think 540,000 patients in the US who had been hospitalized with COVID-19, and 95% had at least one comorbidity. That's really,
Mm-hmm.
really important. Is that it's one of the things that I think gets people frightened, is that they perceive that it is random. But in reality, it is very, very specific in terms of who is likely to have severe disease if you're
Okay, a
older with a
big point there.
comorbidity.
Yeah,
Mhm.
COVID-19 is not random. Most diseases aren't. They may appear so, but at the end of the day, there is some explanation for why certain people have a certain reaction or progress to a severe case of a disease. It's interesting to know. That's a very big point for people to understand, I think. So if you could go on then maybe to tell us a bit, if we move along here to the symptoms, how is that tied into symptoms?
Well, I think the thing that people see, or the primary symptom that is relevant, is the breathing problems. So whether or not somebody has a temperature, somebody has a cough, somebody feels a bit fatigued, at that stage of the disease, it's neither here nor there. And this is how the disease was approached across the world: is don't worry about it, because in those cases, it's mild or moderate. What we're interested in is the people who end up in hospital. And those are the people who can't breathe. And so the question then becomes, what is happening that causes those people who get really short of breath and they're the ones who come into hospital and they can't breathe. And what's remarkable, a lot of them don't even feel short of breath. They know they're short of breath, but it's not until they reach hospital that you realize that they have oxygen saturations that are unheard of for a typical person, to not feel very short of breath. And so that's when they're presenting to hospital. And that's the other part of the cytokine storm. Why does that happen? What leads to it? And that's where our research was focused. And that's where we found the link to an autoimmune response in
Okay.
COVID-19.
So let's break
Primary.
down COVID then into a viral phase and an autoimmune phase.
Yeah, people sometimes say an immune phase.
Immune
Viral
phase.
phase
Okay.
is the early phase where people have symptoms. They have a temperature, they feel a bit unwell. And then the immune phase tends to occur afterwards. And this was in the early part of the pandemic. We may see a different kind of picture as the world has progressed with vaccinations and so on. But early in the pandemic, you had the immune phase, which was tended to be about a week after you had the viral phase. And I think some of the really remarkable observational work done by Dr. Shetty in South Africa, he literally tied it down to the 8th day that patients would get really short of breath, and 8 days after their very first symptoms. And that was a very clear pattern that occurred throughout most of the first and the second waves. And the big question was, why is it so specific? Why do we have that kind of response that occurs in such a defined way in most patients? And that's what I usually am trying to understand when I speak about the way how a disease presents, is that I'm focused on trying to understand those kinds of patterns, that to try and see if I can understand what's going on.
Okay, so in severe diseases, cases of COVID, then what is it that someone actually dies from?
Yes, so this is again an important point that a lot of people don't seem to quite grasp, is that in order to die from COVID-19, especially in a first world country, so let's take it out of the context of where you have no backup and so on. But in a first world country, a patient who gets really short of breath is usually put on a ventilator. Okay. And on a ventilator, they are often getting 100% oxygen. That means the only thing that's going into their lungs is almost 100%. In order for that patient not to be able to breathe, it would suggest that they've got less than 10% of their lungs left. There are very few things that can do that. The only thing that we see in such a short space of time that can do that kind of obstruction, asthma can do it, where the airways get so tight that no oxygen can pass. But that was not the case in COVID-19, because many of the anesthetists says that it was still easy to move air into the lungs. So it wasn't bronchospasm. It was just that there was fluid there, and it didn't seem as though you could get oxygen through. And even with just fluid, what we call pulmonary edema, usually with high pressures, you can get oxygen through to keep the oxygen going in the bloodstream. You can't do that in
And
COVID-19.
why is that?
And that's where it comes down to the basic pathology. When they looked at the lungs, the most important piece of the pathology is what we call microclots. So the blood vessels in the lungs were blocked. So if you have blockages of high numbers of blood vessels in the lungs, no matter how much oxygen you give, you can never give enough. And that's the critical question around severe COVID-19. Why are these patients getting so many little clots all throughout the blood vessels in the lung that prevent them, even on 100% oxygen, to be able to breathe?
So why is that happening? Maybe you could just take us to that next step so that people understand. And again, this is to help us understand COVID targeting. How do we use this knowledge to help understand who's at risk of severe disease? I mean, at this point, a lot of people have had COVID already, whether it was mild or severe, but it still helps us to understand who's at risk. And then maybe we can understand a bit about treatment, because of course, for those who are, whether they're in mining or not, at remote sites or in cities, they still need to understand a bit about what can be done to help people who have then progressed to the severe aspect. So maybe just walk us through that last bit. What is it then that is causing these severe clots? And then maybe we can talk a bit about how that can be treated.
So this is based around the research, as I said, that we had been focused on. And we'd done 2 papers with Professor Uhal in Michigan. And our focus was on the fact that in order to get that kind of microclots in the lung, it seemed to be that there was inflammation in the lining of the blood vessels in the lung. It's what we call a vasculitis, or an inflammation of blood vessels. And that's where it ties into the autoimmune process. And I'll give you an overview of it with this slide here. Essentially, what we were saying was that the free floating ACE2, when the virus gets into the bloodstream, it would combine. And because the ACE2 binds very tightly to the spike protein, these little dots on the outside of the virus. So this is a virus here. This is the spike protein here. And so when you have this combination occurring, where the spike protein is very tightly bound to the serum ACE2, your immune system, and in this case, I've used a macrophage as an example, when it's eating the virus and trying to make antibodies or trigger antibodies, it can't differentiate the ACE2 from the spike protein. And so therefore, it will naturally presume that the spike protein and the ACE2 are part of the virus. And it will then trigger the antibodies through these plasma cells, which will then target anywhere that you have ACE2, which is primarily the lungs, the kidneys, and also the gastrointestinal tract, and also the free-floating serum ACE2, and some of it will be targeting the virus. And it's this whole combination of things that we predict is the cytokine storm. And that's why, as far as we can see, we're using steroids as the primary modality of treatment. I'd argue that we're probably not using enough steroids because it is an immune-mediated disease that would kill the patient.
So what we are in fact doing at that point is suppressing the immune system because there's been an overreaction. Is that the way to look at this?
Yes, there's an overreaction to what is going on. I just realized, is everybody seeing my slides? Are you seeing my slides,
Yes.
Jackie?
Yes.
I think somebody had mentioned that the slides were not visible. But anyway,
Okay.
yeah. So yes, so it's an immune overreaction, and it's that you could call autoimmunity, immune dysregulation. There are different ways of describing that would explain what I'm talking about. But it's just the immune system that is overactive, which is causing the inflammation in the lungs, which then leads to the microthrombi or the microclots, which then stops patients from breathing.
Okay, so what does this mean for treatments then? People will have heard about antivirals. They have heard now about steroids and immune suppression. What role do the antivirals play in this?
So the antivirals do have a role. I think that one of the challenges is timing. And so early in the pandemic, one of the most important antivirals that we had at the time was remdesivir. And remdesivir is still being used, still quite extensively in the United States, probably not as much across the rest of the world. It's more being used for exceptional circumstances. But the main principle of using it was that if you can stop the virus from replicating, then you're likely to suppress the disease. But when we look at the timeline with regards to the inflammation, is that the viral phase, when it overlaps the immune phase, is probably about 8 days down the line from infection. And by this point, the body is already dealing with the virus. So in order for antivirals to be really effective, the big question is about timing. You need to get them in very, very early. But this virus is a master at stealth. And so the main strategy it uses is that it doesn't produce symptoms. So by the time you have symptoms, the virus has already spread. So you're already kind of missing the boat unless you're using antivirals prophylactically, where you're giving it as soon as, say, someone is exposed, they're being given antivirals. That probably would work more effectively. But it's difficult once the virus has already done its work to capture it. You can slow down the replication, but in most immune competent people, they would be able to do it themselves. And someone who is immunocompromised, that could be very, very valuable. So it's about who is the most appropriate to use it.
Okay, and I think this is important for people to know if they're, especially if they're in remote locations, because of more limited resources, perhaps, and so therefore anything they can use that can help to prevent this progressing to more advanced or more severe case would be helpful to know. So the antivirals, it sounds like that's very much about timing. So someone would have to know that they've been exposed and then maybe take that right away in order to get the benefit. If they wait too long, the virus has already entered their system and started that replication process. So it's harder to contain it at that point. You mentioned the immunosuppressed. What about that group of people? Are they at particular risk? I know they feel that they are more vulnerable. Is that in fact the case?
Well, it's one of the things that I think that has been overlooked in terms of understanding the pathology of COVID-19. As more and more data is starting to come out, and I recently looked at a paper specifically in people who had inflammatory bowel disease, who are oftentimes on immune suppressants like tumor necrosis factor, anti-tumor necrosis factor medication, and so on. And they found that they were not at any higher risk for severe disease. And that's a really, really important point, is that we are assuming that because it is a viral infection, you then have a situation, therefore, that people who are immune suppressed should automatically, therefore, be at very high risk. But none of the data suggests that. Even the data coming out of the US, the biggest conditions that were associated with severe outcomes were hypertension, disorders of lipid metabolism, anything associated with obesity. Even fear and anxiety was much higher than immune suppression. That's not what you expect in a viral infection. And most of the pathology coming out about this virus is that even though it infects and spreads throughout the body quite quickly, it doesn't seem to be like a flu virus in that it's what we call cytopathic. It doesn't kill the cell after it has spread from it. The cells still survive. So it doesn't do that much damage to the cells that it infects.
That's very interesting. What about what we're seeing now with Omicron? Lots of breakthrough infections. People have had vaccinations. What's going on with all of that? I know at one point it was thought that the vaccines would help to prevent some of that infection. But now we're actually seeing, okay, maybe it really just helps avoid a severe case of the disease. But there are lots of breakthrough infections going on. People who've had it before or who've been vaccinated and now getting COVID. Can you explain some of that?
Yeah, so well, I think that, as I had said recently, I genuinely thought in January when we saw Omicron spreading through the world, and it was literally just ripping through the world like a bushfire, it was described as the perfect natural vaccine because everybody was going to get it. And if that was the case, we should have had, therefore, herd immunity because everybody gets the virus. You then have what we call mucosal immunity. And mucosal immunity is let me think about a good example is when you're coming into a country and you're going through immigration, the border police do all the passport checks. That's the parallel of mucosal immunity. You can't, if you can't even get into the country, you can't then do any damage inside the country. And so mucosal immunity, that's in the nose and the throat, if it identifies a virus, it immediately puts up blocks and it signals interferon, the virus can't replicate, and it's stopped dead in its tracks. So that's mucosal immunity.
Mm-hmm.
And so if everyone got infected, we should therefore have ended the pandemic. And that's now really, really puzzling. Why is it that the pandemic, even though we've had the virus go through the whole world, and on top of it, we have had 11.3 billion doses of the vaccine, why is the pandemic still ongoing? I don't have a clear answer for that. But I do have the privilege of speaking to a number of experts, and one of them that I spoke to, Gert van den Bosch. Now, um, Gert has been criticized by a lot of scientific experts who disagree with his positions because he last year was concerned about mass vaccination in a pandemic and the risk of viral variants. And at the time, that was in March 2021, it was thought that that was very unlikely to happen. Now, we still can't necessarily say that Omicron is related to mass vaccination, but whichever way we take it, we have got viral variants that are evading vaccines, which is essentially what he was concerned about at that point last year.
Mhm.
So, my view is very simple. If at that point last year he had a pretty good prediction as to where things would be, I would hesitate to discard what he is saying now as to the next steps. And so I recently interviewed him, and what he said was very sobering. And I think what he is concerned about is that the virus has already evaded the vaccines. But more complicated is that the 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 vaccinees, the people who have had the vaccination, are almost primed to produce antibodies primarily against the spike protein that they have been vaccinated against. And that's the power of the vaccine, is that this is strength and potentially its weakness, in that it's hard for the immune system to switch tacks, to change its immune profile to something else. And in a sense, this is what we see in dengue, where one virus has infected the person. They then get infected by another virus, but the body responds by producing antibodies to the first virus. And that's technically the pathology of dengue hemorrhagic fever, where you have this very severe immune response. And so his view is that at the moment, because the body can't get rid of the virus, it's effectively, he calls it parking it. And I don't fully understand this yet. I'm trying to see if I can get my head around it. But it's not able to fully neutralize the virus, and the virus will be working to get past that neutralization to become more virulent. That's a big worry.
Right. So far we've had Omicron, which is relatively mild compared to Delta. I guess his concern then is that we get a more severe variant, which is also very transmissible, and that would be a much worse scenario. So what does the endemic situation that we seem to be progressing to look like? Is this it? Does it continue like this, where sort of the variants pass around and can people get repeated versions of a COVID infection, or does it settle down at some point? What should we be looking for?
Again, it really is at this point a guess. And so I would hesitate for anyone to say that this is what it's going to be. I think this is what we may hope that it is, that it becomes endemic. And the hope is that it will become like what happens with the flu. So every year there's a new version of the flu virus, and there's a vaccine, and it tries to minimize the amount of deaths that occur with the flu each year. And I think that is the perception as to what we're hoping for with COVID-19. The problem is that we don't have a year, is that at the moment we're needing to do boosters almost every 3 to 4 months. And more, I think some of the big agencies, the FDA, the CDC, the European agencies, are starting to realize that that's not sustainable, not just in terms of cost and the systems, But if there's one thing I've learned about the body is moderation. Anything that is done too much can lead to unforeseen problems. And we genuinely don't know what some of those risks are going down the line with a fourth vaccine dose. But
Mhm.
there is some evidence that there is benefit, certainly in Israel, but the benefit is short lived. Is it worth
Mhm.
still doing? That's a question that it varies, I think, depending on the characteristics of each individual patient.
Mhm. So that I think has been a bit of a surprise, that the waning efficacy, and then that need for boosters coming fairly quickly. So that's the current state. I guess one thing we should talk about here, and certainly something that we should be aware of for the in the mining business and in other businesses, is how widespread long COVID is. I mean, there was a study just recently showing that up to 30% of people who get COVID and may end up with some version of long COVID. And there have been other studies that say even more. So maybe you could distinguish for us, what's the difference between long COVID and long-term effects of COVID?
Yes, I think that's a very important question, Jackie. Is that people perceive that long COVID is the same across the board for all people. I in my research, I differentiate between complications of COVID and long COVID. So what I mean is that if you had somebody who was very unwell with COVID-19, they're on intensive care, they're on a ventilator, they recovered, but they've got a degree of damage to their lungs. They may have some degree of myocarditis after the infection, because that can occur, and they're short of breath. That's, in my view, a complication of COVID, of severe COVID-19. Long COVID, however, is not necessarily related to the severity of the infection. And this is why the numbers
Mm.
can be so high. So people can get infected, have relatively mild or moderate disease, and then what they end up with is persistent symptoms beyond the mild and moderate disease that can be lasting for 3 months, 6 months, and in some people up to 2 years. That's what I describe as long COVID, and it is extremely debilitating. In the context of the mining industry, I think that certainly from the financial sector, people don't want to talk about it because it's going to put them across as being ill. So you will find that people try and mask the struggles that they're having.
Mhm.
And you'd probably see a similar problem with regards to your mining workers who are working in mines. If they're just telling their bosses that they're feeling tired all the time, depending on the kind of work that they're doing, that's the kind of situation that could get them laid off. They're not going to want to talk about it. So you're going to find a lot of people are fighting and struggling to cope. And the biggest associated feature is fatigue. A lot of
Right.
them are
Yeah.
completely shattered.
Very, very important to know. I mean, safety is so important in mining, where people are operating heavy equipment. Just, safety around the mine site, whether they're operating heavy equipment or even in offices, safety is paramount. And so this is important for people to understand, that this is affecting quite a few people, and that staff, mining company staff, other sectors it applies so broadly, should be aware that this is a real problem and try to understand it, but also to help provide support for those workers who are suffering from it, so that they can keep up, in terms of safety, but understand the implications for staffing, for performance. And this is not limited to just the workers, to say, on site. We're talking about at every level. Potentially, long COVID could affect management, board members, anyone at all. And so what do we need to do? First, we need to be aware that this could be a problem. And then we need to understand how it works, and what can be done to support people. So again, very, very widespread, but I'd say very important to understand this, certainly in remote locations where some of the resources may be a bit more limited. So what can be done then for those who have long COVID? What options are there? And especially given that it can last so long, what can people do?
This is one of the areas that I'm now focused on in terms of trying to understand the patterns with long COVID. And I say quite, not categorically, but I say it's an important point. If you don't understand severe COVID, I think you will struggle to understand long COVID. And long COVID, as far as everything I've looked at, is immune mediated in the same way that severe COVID is immune mediated. And so what we're looking at is primarily a persistent immune response that is occurring after someone had the infection. That's what I describe as long COVID. And everything about it seems to point to the fact that it's a gut related disease. And that's probably the bit that I'm working on now to try and clarify exactly how that manifests in terms of the symptoms and also in terms of how you can go about trying to help people who are suffering with long COVID. Because if we have Omicron circulating all the time or becoming endemic, we are then going to find a situation where long COVID numbers are likely to increase.
Yes, it is a concerning situation. I guess the question too for those in the in mining, how do you screen for this? First of all, even to understand who might be vulnerable for severe COVID going forward, is it easy to understand who has high levels of serum ACE2? And then for long COVID, how do you screen for that? How do we help people understand who has it? Because the person who has it may not even understand that that's what's happening to their own bodies. They may feel more tired. They may have this loss of taste, some headaches. But how do you really know who has it?
Yeah, so in terms of the first bit, this is the hope that I'd have to get some answers or ways to screen for severe COVID. And based on our research, it suggests that a simple blood test, it's not yet available to most people, which is to measure serum ACE2, could identify people who are at risk for severe disease. In terms of long COVID, now, again, there's still a lot of research going into that. I do have some thoughts on it. I probably can't share them publicly as yet, but I do believe that there will be blood tests that can be done that would allow us to be able to identify one, how significant the problem is. That's the first thing, so that people are no longer just saying they feel tired. We can find an actual marker that tells us that this is something here that is real. And then two, when you're doing your therapy, you'll be able to monitor these markers to see whether or not your interventions are helping. Some of the work coming out, I think, from, say, InCell with measuring cytokine profiles, that's with Professor Bruce Patterson, also are already ways where you can measure serum markers associated with long COVID. And so there's still a lot more work to be done. But it is something that is a growing area. And I think the US just recently pledged to focus research on specifically this.
Okay. Thank you. And we have a question here. This is really for you. Long COVID patients and diet. Is there anything you can say about that one?
It's one of the things that I am very focused on in terms of, I have seen patients for many years, and this is even before the COVID pandemic, who were having problems, health problems, and you can find exactly where it ties to their diet. And this is why I guess my approach with long COVID is along those lines, is that the same people that I had advised about their diet before COVID are also the same people I'm finding that get long COVID. And so I know the two are very closely connected. And most of the research I'm doing is suggesting that the gut inflammation, the gut microbiome changes that occur in these patients are what seem to be driving a lot of the symptoms. And they have to focus on their diet in order for them to try and get better.
So I think it sounds as if COVID is all about improving our lifestyle, but also focusing very much on diet, certainly for the long COVID aspect. And this is where people can get advice. Someone has asked a little bit about vaccines and the different platforms. Maybe you could just explain broadly what those are, the two different key types that most people, I think, at least in North America, have had.
Yeah, so the two main types are the mRNA vaccines and the adenovirus vector platforms. Those are the two main ones that are in use across the world. There's also protein based vaccines that are coming, but they're not yet used as widely as these two groups. And the main difference with them is that the mRNA vaccines, and that's the Pfizer Moderna, they have taken the almost the code of the spike protein from the virus, put it in a lipid particle, and when it's injected and taken up by the muscle cells, it then makes spike proteins that are still attached to the muscle cells and then trigger the immune system to make antibodies against it. And it's been very, very successful, probably more successful than anybody could have predicted that it would work. The other version is the adenovirus vector platform, and there they've taken almost a virus that can infect cells, taken out the DNA for that virus, replaced it with information about the spike protein. So then the virus still infects the cell after infection, but it can't make viral particles. It can only then make more proteins, again, spike proteins, to trigger the immune system. And both methods create spike proteins that then cause the immune system to respond. It's just that one of them does it in the nucleus, that's the adenovirus, and the other one does it outside of the nucleus of the cell in the cytoplasm. Mm-hmm. But the spike proteins are the mechanism that triggers the immune system.
Okay, thank you for that. We have a question here about vitamin D and its importance. Maybe not quite this, but maybe you could tell us a bit about the role that vitamin D would play for COVID.
Vitamin D is an important one, and it hasn't been given as much attention. I think we have to thank Dr. James Lundy, certainly on LinkedIn, for continuously hammering home the point about the importance of vitamin D. Vitamin D has so many functions in the body that it's difficult to tie it down to any one specific thing that it does. However, the biggest issue that I think that vitamin D helps with in terms of severe COVID-19 is that there's a balance between two things. Vitamin D levels, it's almost as if you can imagine two things here. One is vitamin D, the other one is fibrinogen. If vitamin D is low, fibrinogen is up. And if fibrinogen comes down, or if vitamin D comes up, fibrinogen goes down. The fibrinogen is what helps your blood to clot. So if you have more fibrinogen in your bloodstream, you're more likely to make blood clots. And so we know this, that vitamin D deficiency has already been associated with DVTs, that's clots in the legs, clots in the lungs, stroke disease, heart attacks. Anything that can make your blood clot is associated with vitamin D deficiency. So in the context of microthrombi in the lungs, if you have a higher propensity to make them, that 2% difference could be the life and death. And this is where I think vitamin D comes in. It won't necessarily stop someone from getting on intensive care, but it may reduce their fibrinogen levels enough that they don't die on intensive care. And that's where I think vitamin D, and it's so easy to replace. I can't see a good reason that anyone wouldn't be supplementing their vitamin D, especially if they're in a temperate climate.
Mm-hmm. Yes, good for everyone to know about that. Certainly, that can be advice that's given to those who may not be aware of the importance of vitamin D. And so good to know. Just going back to a question earlier about the severity or mildness of the viral phase and what that correlation is with the immune response that happens. Could you just maybe address that for us?
I don't think that it's necessarily connected, actually. So meaning that in the early phase, some people can have really minor symptoms, and they oftentimes can feel better and then suddenly get very, very unwell. So I don't think that the severity of the viral phase is necessarily predicated on how severe the immune phase is. And I think that's one of the things that catches people out, is that they have been not so bad, and then all of a sudden they get very short of breath. And this is something that is part of the reason why it's so hard to predict who is going to get so unwell to end up in hospital.
Mm-hmm. So as we look at the broader, I guess, population, then beyond saying, improve your lifestyle, try, if you have these various conditions, try to get them under control, the comorbidities that might lead to some of the more severe outcomes. Beyond that, what other, take your vitamin D. Is there anything else that patients or that, people should hear that could help them manage what they're doing? So far, people have had to lock down, they've had to mask, they've had to, take all sorts of precautions. And for the last 2 years, I guess at this point, a lot of people are getting tired. Things have been opening up. So far, Omicron has been relatively mild. Is there anything else they can do that might, if things got bad, maybe we see a worse variant, maybe, things somehow unexpectedly turn worse again? What can people do in general to sort of stave off the worst?
Yeah, this is where our research needs to go at this point. And so I believe in contingencies. So the best outcome is that it becomes relatively mild, doesn't cause any further problems, and that's it. That's the best outcome. The worst outcome is kind of like what Gert van den Bosch was concerned about, in that the virus becomes more virulent and just as infectious, and then starts to cause very severe disease again. Our challenge is that I don't know that we have any current mechanisms for being able to stop that very severe form of disease with what we're doing. So, this is where I think the understanding of the disease comes. Because if we understand that this is an autoimmune disease, it opens up a treasure trove of drugs that we have in front of us that can treat it. Because we treat autoimmune disease all the time. Every day across the world, people are treated for severe lupus, rheumatoid arthritis, even multiple sclerosis is an autoimmune disease. And we use very high doses of steroids. We use drugs like cyclophosphamide, mycophenolate. We have a lot of drugs that can suppress the immune system. My hope would be that people understand the disease enough to recognize when we need to use this. And I think one of the problems is steroids are very powerful drugs. They should not be used unless you absolutely have to use them. And so some of the issues that had, I think, happened in different parts of the world is that people were using steroids all the time, which is dangerous. It carries risks with depending on the characteristics of the patients. But when you have people who are unwell with COVID-19, especially from a respiratory point of view, I think immune suppression is absolutely critical. But here's the problem. I think that when we look at the vaccinated cohort, I don't think we're going to see that much lung disease. I think the disease is going to change. The mechanism that it causes severe disease about is likely to be different. And that may cause some confusion as to what exactly is causing severe patients to deteriorate. We need to be on top of that, else we could miss the opportunity to
To mitigate.
for,
Yeah, and I
to
think that
mitigate.
again is something the mining industry is well aware of. How do you identify the risks? And once you know what they are, once you know what you don't know, it's about understanding all of that, but certainly mitigating risk wherever possible. We've had one question here on what types of antivirals would you suggest if you get COVID-19? Would you, is there anything you can say there? We did talk a little bit earlier about antivirals. Maybe just mention that again.
Again, I think that the challenge is that if you don't have severe disease, is it appropriate to use antivirals? And you have to remember that the antivirals at the moment that are not even in circulation, the Pavloxoid from Pfizer, and I've forgotten the name of the other one that is out there. These are very powerful antivirals, and they do have side effects that are associated with them. And so you would want to limit the use of it to patients that really need it. Now, how do you select those patients? It has to be, again, about symptoms. If people are having prolonged infections, so if they're positive for Omicron and they're they're not clearing the virus, and they're then starting to progress to be unwell, then certainly an antiviral there would be of tremendous of benefit.
Mhm.
But whether or not we can reach the phase that I think Gert had mentioned, where we need mass population-wide use of antivirals, there are very few options that would be safe at a population level that could be used.
Mm-hmm. Yeah, we have a comment here about Dr. Chetty and what he's been teaching. If there's a high infectivity, high kill variant, and if that does emerge, people might appreciate what he's been teaching. So you did allude to that earlier, talking about, the 8th day, recognizing when the transition is made from a viral disease to an immune disease, and how that might be treated with immune suppressants, among other things. Right. Okay. Well, thank you. I don't see any other questions at this point. I think this has been really wonderful. Thank you so much for your insights. What we said here, applies not just to mining. In other words, trying to understand the disease so that we can help those who may have COVID or have had COVID, now have long COVID. Certainly understanding who is vulnerable, encouraging people to have as healthy a lifestyle as possible to reduce the comorbidities that are associated with severe disease. But certainly in remote areas where resources are a little more limited, to really understand how we can help people, vitamin D, diet. Certainly there are some treatments that are available, but if you understand the disease, then you can know what is most appropriate and how it can be used. So I do appreciate, any last words before we wrap up here, Dr. McMillan?
I would say that certainly when you look at your sector, the mining sector, it's very closely tied to the financial sector. This is an example where I think that we haven't had enough of the corporate sector stepping forward to try and find solutions, because COVID-19 is impacting everyone. And I think there is almost the expectation that governments will do this research, find these answers, and everything will be okay. But it needs more than that. Mm-hmm. And if there's any appeal that I would make, is that I think that now sectors need to come forward, need to be supporting research, need to be finding ways that they can help to find solutions for COVID-19, because the impact will be felt across the world in every sector. And it, as you said, is very relevant to the mining sector as well.
As you've mentioned, I think everyone sees this, COVID has impacted the supply chain, for example, shutdowns, people unavailable. That carries right through and disrupts all sorts of chains. And so that's having such a broad-based impact and helping to fuel some of the inflation everyone's feeling now too. So certainly wherever we can support the work that's being done, let's not just assume everyone else is doing it. It takes a lot of time and resources to get to the right answers here, and so important for everyone. So thank you for that, and appreciate you being with us today, Dr. McMillan, and thank you for those who joined us, and we look forward to doing another The Mining View in the future. We'll have other interesting topics, but once again, thanks very much for being with me.
Thank you very much, and I look forward, if I need to, sharing in the future.
Thank you.